Okay, today I'm going to show you how we place sealants. I super prefer the glass Ionomer sealant. Our product here is Fuji Triage. The reason is that it inundates the occlusal surface with fluoride, and so that helps the caries be reduced. What is the final, or what are we really trying to do with sealants? Are we trying to cover the occlusal surface? Are we trying to make it look pretty? Or are we trying to reduce caries? And if you look at the data, and I'll put the information here in the description of this video, if it's a resin sealant or if it's a glass ionomer sealant, you're going to get the same results as far as caries reduction. And in fact, the glass ionomer sealant usually does maybe a little bit better job than the resin sealant. Now, there is data that shows that the resin sealant might stay on better, but that doesn't matter. That's not our goal with the sealant. It's to reduce caries. So the reason that I like the glass ionomer too is for your younger patients, you do not have to use etch, meaning you don't have an extra product that can gag the patient, and it's very tough to get isolation with a younger patient. So with the glass ionomer, if we have a little bit of contamination, it's not the end of the world. The other thing too is obviously simplicity. Do I want to have two different types of sealants? No, I would rather just have one that's applicable for all. What you are going to see is that the glass ionomer sealant goes on a little bit thicker than a resin sealant, but within a day or so, the child or the patient is going to grind that down so that it's super smooth for them. So we'll see how this all works, and then again, read the description and all of the data in the description that shows you the glass ionomer sealants work just as well as resin sealants. So obviously we're showing it to you on the typodont if you're doing it on the mandible or the maxilla, usually we're isolating with the cotton roll. But what we do is we'll put it right here on the occlusal surface of the tooth, and then usually we have a bent microbrush, and I like to keep it just a little bit thicker, so I'm going to just kind of let it flow or kind of drag it just lightly, so that I'm covering the entire occlusal surface, and I also want it to be super smooth. I have seen some doctors that try to wipe it and make it really thin, kind of like a resin sealant. Again, you want to leave it just a little bit thicker so that it is super smooth and that it has retention. Light doesn't matter. This is a chemical cure, so usually you're going to wait about 20 to 30 seconds. A lot of times if I'm doing multiple teeth, what I'll do is I'll do one side of the mouth, and then because the patient is going to be continuing to stay open, I'll already start working on the other side of the mouth and wait for this to cure and this to cure. So my instructions to the patient are that they will feel like it's a little bit like they've got a piece of lettuce in between their teeth for the next couple of days, and then they'll just grind it off smoothly and they won't notice it within a couple of days. So I usually kind of keep an eye on it, and I can use either an Explorer or my microbrush, but I'll usually just kind of poke at it just a little bit, and then if it's still soft, I'll just keep waiting for it. But usually you're looking at 20, 30, 40 seconds, and it's solid enough that you can go on to the next one.